Hey, welcome to the Healthful Woman podcast, the fastest growing podcast in women's health. Today's Monday, May 20th, 2024. Today, I'm joined again by Dr. Helen Feltovich, and we are going to tackle a Mailbag podcast together. If you heard the podcast last week with Helen, you already know how smart, interesting, and funny she is, so I'm certain you will enjoy today's podcast as well. The questions we are going to be answering are from our wonderful listeners, Chaya, Anna, Mary, Jackie, and Sarah. And the topics we are going to cover are a bilobed placenta, activity restrictions with a cerclage, are IVF pregnancies high risk, miscarriage, and peripartum cardiomyopathy. All right, The Unexpected, the book I wrote with Emily Oster, is available wherever you buy books. We had a great book signing event last week at Politics and Prose Bookstore in Washington, D.C. Shout out to all the readers who came out to hear CNN's Abby Phillip ask Emily and me questions about the book, and a super shout out to those of you that asked questions from the audience and came up to talk to us afterwards. It was awesome. Thank you. This week, on May 22nd at 7 p.m. at the JCC on the Upper West Side of Manhattan, there's going to be an event and book signing again with Emily and me. It is going to be hosted by Laura Jarrett from NBC and Poppy Harlow, who was at CNN until recently. So please sign up for that. We'd love to see you and meet you. Final reminders, please do follow me on Instagram. My handle is Dr. Nathan Fox. That's one word, Dr. Nathan Fox. Second, please do email us any questions you might have for our Mailbag podcast. You can either email them directly to hw@healthfulwoman.com or go to our website, www.healthfulwoman.com, and click on the link that says send us your questions. Reminder, these questions are for Mailbag podcasts, not for the personal medical advice you need answered quickly. For those, ask your doctor. All right, thanks for listening. Enjoy the ad for the book, followed by the Healthful Woman Orchestra. We will be dropping a podcast on Memorial Day, so see you all next week.
Hi, I'm Emily Oster.
Hi, I'm Nate.
Here's a piece of data for you. About 50% of all pregnancies include some type of complication, whether that's a miscarriage, preeclampsia, preterm birth, postpartum depression, or other. I'm not saying this to scare you, but the reality is that we don't talk about these complications very often, and yet they affect an enormous number of people. That's why I've teamed up with Dr. Fox to write a new book called The Unexpected: Navigating Pregnancy During and After Complications.
The Unexpected is a book we hope no one needs to read, but we also want everyone to have access to. It starts by laying out the data on pregnancy complications from first trimester to postpartum. For each one, we try to answer a few questions. What is the risk of recurrence in a later pregnancy? What treatments might lower that risk? And how can you better prepare if it does happen again?
Then we guide you through how to have more productive conversations with your provider. Data will help, but to make these hard talks as useful as possible, you need a script and a way to structure the conversation.
It's important to us that we bring these maternal health issues into the light so that necessary research and policy change can hopefully happen.
And above all, we hope it helps pregnant women feel less alone and more informed and prepared for whatever the future brings. You can order The Unexpected now, wherever books are sold.
Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. All right, so I got Helen Feltovich in the hot seat here. We just recorded a podcast, which probably dropped, I don't know, a week or 2 weeks or whatever ago. And I told her just today that I'm going to be doing a Mailbag podcast. Helen, thanks for agreeing to this.
I'm terrifying.
You don't know any of the questions that are coming. This is not, as I said before, like quiz show where we gave Van Doren the answers in advance. This is like, you even know the reference for that?
No.
You were busy dressing windows instead of watching movies in the 90s. All right.
Trimming them.
Trimming them. Oh, that's right.
And by the way, just for everybody to know, I wasn't actually asked about this in a way that I agreed. I was just told this was happening.
No, but
so there is that
medicine,
minor...
that's what we mean by asked.
Okay, all right.
Told by someone else. Okay, so what I'm going to do, since Helen, you're new to this format, I'm going to read the question, and we're going to talk about our thoughts on the answer to our listeners' questions. So this
Sounds
is
good.
as if someone asked you as an obstetrician, as a maternal fetal medicine specialist, as a human being, what are your answers? First question is from Chaya. I'm 30 weeks pregnant with my third and was diagnosed with a bilobed or almost succenturiate placenta with a marginal cord insertion at my 20-week anatomy scan. My OB seems very unbothered and calm about it, and Google is being very unhelpful as usual. I'm curious if you would discuss what this is and if there's anything to worry about. She has a second question. I've also had a vanishing, what looks like identical twin at about 6-ish weeks, and I'm wondering if that smaller attached lobe on my placenta can come from that. I haven't seen any research available on that. Thank you, Chaya. So first, Helen,
Yes.
how do you explain to people what is a bilobed placenta and a marginal cord insertion, and whether you should be unbothered like Chaya's OB or bothered like Google is by these findings?
Dr. Google is bothered by everything.
Yes, Dr. Google's definitely a pessimist.
Dr. Google is a pessimist and full of lots of information.
Yeah.
The answer is unbothered.
Okay.
So a bilobed, about all of those things, the
Right.
bilobed part, the possible succenturiate part, and the marginal cord insert. This
Right.
has changed recently for people like us, Nady. We used to get all bothered by marginal cord inserts now, but
Right.
but recent evidence has suggested it's not a big deal. I always look again because you want to make sure that as the placenta develops, it doesn't wind up being filamentous,
Right.
which means it's in the membranes, which
Right.
is a whole different thing that you
Right.
don't have, Chaya, so
Right.
don't worry about it. But that is very, very rare. So bilobed just means that instead of your placenta, like all the cotyledons and, all the functioning units of the placenta being together in one sort of like half moon-shaped mound,
Right.
you have two separate parts of it
Right.
that are connected by membranes in the middle. And sometimes the cord can come out of the membranes in the middle.
Right.
That's rare, and that's not what you have because that's not a marginal cord insert. The marginal cord insert just means that the cord isn't coming out like pretty much smack in the middle or around that area.
Right.
And succenturiate is a different version of that, where I don't know how you think of this, Nady, but to me, bilobed is more they're sort of equal lobes, and you may or may not see the cord coming out from the center. And succenturiate just means there's like a little island over here that doesn't, that certainly wouldn't have a cord on it. That's just sort of over there.
In my brain, I think about it as bilobed is sort of the classic picture of like two cherries sitting next to each other.
Yeah.
Whereas a succenturiate is more like the earth and the moon. There's like a big placenta and then like a little satellite placenta off to the side.
A little one over there.
And honestly, functionally, as far as we know, there's really not a risk of anything.
NBD.
Yeah.
NBD.
And no big deal?
No big deal.
Yeah. And then the only real issue if there's a bilobed or succenturiate placenta is please make sure the obstetrician
Pulling it
knows
off.
that when you deliver and the placenta comes out, all the lobes come out, because otherwise you're going to be coming back to do it again several weeks later. So that's really it. Again, marginal cord, where it's not plunking into the bullseye, but more marginal, not such a big deal as well. So yeah, I agree with.
Just don't pull it off. It's a little easier to pull it off during the delivery. But even if you do that, like, meh.
Yeah, we can go get it. So,
just get it.
So Fox and Feltovich agree with your obstetrician, not such a big deal, and we will differ with Google on this one. Now, tell me about the vanishing or vanished twin that Chai asked about in the second part of her question.
Yeah, also NBD.
Good.
I want to take a moment and just acknowledge that pregnancy loss is hard. It's easy for people to think it's not a big deal when you lose a pregnancy so early, especially if it's a twin pregnancy, because, you've got another one that's ongoing. So I just want to take a moment to acknowledge that can be painful in pregnancy and acknowledge your emotion around it. That said, it is not a big deal at all from the standpoint of your ongoing pregnancy. And I can think of no pathophysiological possible path to having a bilobed placenta because of that vanishing twin.
And especially when Chaya was saying that her twins were identical, and if it was identified early as identical, that means there's only one placenta anyway, so that wouldn't really do it. Yeah, I mean, the idea of the term is a vanished twin, which is sort of an odd term, but it sort of means there was a twins and then the second one's gone, vanished, like magic. But essentially what it means is you have...
It sounds scary.
Yeah, you have a twin pregnancy, and you either before you see 2 heartbeats or after you see 2 heartbeats, at some point there's only one ongoing baby, right? And the other one, either the heartbeat stopped or never developed. And if that were to happen later in pregnancy, we don't typically call it a vanished twin. We would either call it like, an IUFD, like a fetal demise of one of the twins, or, there's different ways we describe it. Vanished twin typically to us implies it happened very early in pregnancy, like in the first trimester, under 10 weeks, under some gestational age that people probably disagree on, but
and has no effect.
Right. And if it's early, it really has no effect. There are some studies, I think, that showed possible risk of growth restriction. Probably a lot of that's because a lot of these pregnancies were IVF. And so it's hard to know if it's really that. But yes, I agree. When it happens early, there is, for many people, sort of a moment of sadness because they were sort of excited about having twins at first and now it's not. Or they learned about this the day they found out, like they thought it was one, and they come in, someone says it's 2, but it's really only 1. And then there's sort of confusion about how do you feel about that.
Yep.
And for some people who either medically feel twins is not a good idea for them, or just they were not really ready for twins, for some people, potentially it's a relief that they don't have to worry about that in the same way. So there's a lot of different emotions that happen.
So many emotions.
Yeah,
Yeah, I think it's easy to get a bit of disenfranchised grief around that. And, just a surprise, hey, there were 2, but now there's only 1. But in terms of safety to Chaya and her baby right now,
fine. Yeah.
NBD.
All good. All right.
Fox and Feltovich agree again.
Unbelievable. All right, here's the next one. This is definitely a topic I'm interested in, and I assume you are too. From Anna. Here we go. I'm currently 22 weeks pregnant with a history-indicated McDonald cerclage.
Here we go.
Due to 22-week PPROM in my last pregnancy. My question is regarding activity and exercise that is safe to do during my pregnancy. My MFM did not put me on bed rest and said, besides not standing or walking excessively, I have no activity restrictions. But he says there is no data to guide me on what precisely, quote unquote, excessive is. As a result, I'm limiting my standing and walking because I do not want to contribute to PPROM and I do not know where the line is, but my health would likely be better if I could go on walks or do light exercise. How should I think about balancing this? And can someone please do an RCT, randomized controlled trial, where women with cerclages have monitored exercise so we can get some data to guide us? Thank you. That's from Anna. Good question, huh?
That's a great question. And it's the question, Anna, that people like Nady and I are asked by every single person who has a cerclage. And we agree with your MFM that there aren't great data to guide us. That said, there are way better data these days than there has been in past years and decades. So for instance, when I trained, if a person had a cerclage, what you have is called a history indicated cerclage. That means that something in your pregnancy history has inspired the recommendation for you to have a cerclage in this pregnancy. There are also ultrasound indicated cerclages, right, Nady, for a short cervix, or exam indicated cerclages for a cervix that is dilated.
Or feels like an egg.
Or feels like an egg, feels like a very soft-boiled egg. That's right. But in answer to your question about activity level, the really great news about today is that we know from growing evidence, both that being active is healthy. And, remember the old days, Nady, where we would say, you shouldn't start an exercise program in pregnancy, like that's too much. And then we would say, well, if you're like at this level of activity before you get pregnant and you want to continue it, that's fine. And now we're like, get thee to the gym.
Right.
So all of that has really changed. And you kind of nailed it, Anna, when you said it's not healthy for me to be limiting my activity. You are absolutely right. Obviously, for you, it is not healthy. Some people feel like, and this is exactly what I say to patients, Nady, maybe you're exactly the same. If whatever you're doing makes you feel better, then do that. And for some people, being like limiting their activity a little, given that we don't have any real data, some people may feel that limiting their activity is something that they can do to improve their outcome, and that might feel good. We would absolutely not recommend bed rest. That we know is just straight up dangerous. We didn't know that 5 years ago, but we know it now. But for other people,
I think we knew it 5 years ago.
Did we?
The bed rest is dangerous.
Didn't that come out like right before the pandemic? Well, it is 2024, isn't it?
Yeah.
Wow, I'm getting old. Okay, yeah. Well, when I started training, we didn't know that. And for other people, they feel much better and are much healthier if they are not limiting their activity.
Yeah.
So bottom line is, whatever makes the person feel least anxious, you know, what's good for the goose is good for the gander, right?
Mm-hmm.
So whatever makes the mother least anxious is also going to be, I think, the best for the baby.
Yeah, I'm very, very similar. Essentially, I agree, Anna, with your MFM. The data is terrible. So we don't know for certain. But it's also very hard to study, even if you did that randomized controlled trial, because it's probably different for different people. There's probably not something that on average is the right thing to do for everyone. Number one, like what Helen was saying, there's the mental aspect of it. So for some people, rest will make them feel better. For other people, rest will make them feel worse, and vice versa. And it's probably different. Everyone's uterine activity is going to be different, and sort of how it responds to activity. So what I typically tell people is, I don't recommend bed rest, and I don't recommend training for an Ironman, right? So those are very far apart from each other. In the middle is very gray. And I believe that probably each person falls somewhere within that gray in a different place. And I get very hokey and say, listen to your body, right? So I say,
me too.
So be active. And if doing something causes contractions, cramping, pressure, back off.
Yep.
And if you feel fine doing it, it's probably
or
fine.
Extreme shortness of breath.
Yeah. And if you feel fine doing it, it's probably fine. And again, the same thing, I tell people the same thing. If you are going to feel better saying, I'm doing a little bit more, I'm going to take it 2 hours a day and put my feet up, because great, like God bless, like that's fine, as long as you're not doing complete bed rest. So we're aligned, as they say, as the kids say, we're aligned.
Fox and Feltovich together again.
Love it.
One little tiny note of hope for the future about that, Anna, though, is that's exactly what our lab collaborative is trying to address, because what you're really saying is what sort of biomechanical changes could happen in my body to cause, a 22-week delivery. And that's exactly what people like us and others are trying to figure out. And fun fact, unpublished fact, only for Nady's podcast.
Okay, hot take. Here we go.
Listeners to know. So we did, I think I mentioned our research in the podcast that we had. And we looked at persons undergoing normal pregnancy. We scanned all kinds of maternal anatomy features. So we did, serial scans of the uterus. We did transvaginal scans to look at the cervix and the lower uterine segment. We did these in both laying down and standing up positions, and just in a really small group of people. This was at Intermountain in Provo. And then the data was sent to Columbia, and they made fancy models out of it. And fascinatingly, there was no difference.
I know exactly what you're going to say.
What am I going to say?
Yeah, the standing up doesn't put any more pressure on the cervix. It also makes sense because anatomically it pushes the uterus down on an L shape, so it probably closes the cervix by standing up.
Bingo.
Yeah,
and that's
it's like stepping on a garden hose.
Yep, it's like stepping on a garden hose. Yep, exactly right, which is, at least presumably also what a cerclage does.
Yeah.
It changes the forces on the cervix. And so it was such a small subset, and we've never published it. We probably should, because it's really interesting. But for the first time when I reviewed those data, I was like, oh, the stress forces on the internal os are no different standing up or laying down. This is why bed rest doesn't matter.
Right. It's true.
Loved
All right.
it.
Awesome. Anna, great question. All right. Next one is from Mary. And this is a name that you and I can't pronounce properly. Mary.
I know.
Two Midwesterners trying to figure this out. All right. My family makes so much fun of me for this. I apologize to all of you East Coasters out there. All right. So Mary, Here we go. Thanks for this amazing podcast.
My mother's name was Mary, so I say it right.
God
Mary
bless
Margaret.
You. All right. Thanks for this amazing podcast! Exclamation point.
Woo.
I really enjoy it. Another exclamation point.
It should be a double one after that.
Someone that went through IVF, should they go to an MFM just because they became pregnant through IVF? If everything is going well in their pregnancy, should they still be going to an MFM? Thank you.
That is a great question. And I would pitch a question right back to Mary, which is related to Anna's question, actually. How do you feel? And how much do you like the person? Like if you have a wonderful MFM like Nady, probably you want to stay with that person because you like them. But if you have a cranky MFM like, I don't know, me, then you might want to just continue with the person that you get your regular GYN and obstetrical care for. The truth is that there's a lot of, this sort of gets at the heart of the question of what is a high risk pregnancy versus a low risk pregnancy. And I tend to sort of steer people away from those kinds of labels.
Right.
Because when people think of themselves as high risk, that feels scary, I think. And, Nady, you've heard patients say this all the time too. Sometimes patients will say, oh my gosh, I went from like low risk to high risk in an instant. And that was terrifying. And, what does this mean? And so I kind of steer away from those labels. It is true that people who have undergone IVF have a little tiny higher risk of having a birth defect. And therefore you would be very wise to get a full detailed ultrasound with an MFM. But beyond that, who do you like? Who do you want to be with? Who, how do you define yourself? That's my answer.
It's so interesting. Just yesterday, someone asked me, it was a very similar question, but not because at IVF, because I think they were 40 or something like that. And they said, are we high risk pregnancy or are we low risk pregnancy? And I said to them, which would you like to be?
Exactly.
I always ask that, would you like to be high risk?
Fox and Feltovich aligned again.
Some people want to be like, they're like, no, I want people to know that this is like serious stuff. Like, fine, you're high risk pregnancy.
Yep.
And if they're like, no, I feel great. Like, fine, you're low risk. And I tell people, the analogy I use is I say risk is like height, right? So I'm 5'11". Am I tall? Well, maybe. If I'm standing in a kindergarten class, I'm very tall. But if I'm standing in an NBA locker room, I'm very short. And so risk is the same way. So sure, an IVF pregnancy has more risk than, all things being equal, a non-IVF pregnancy, but it has way less risk than if you were carrying twins or had hypertension or diabetes or whatever it is.
A million different
right.
things.
And so, and I sometimes like to tell people like where they rank in my waiting room, you're top of the food chain, you're bottom of the and so it's really one of those things. And ultimately risk is also not about the person being high risk or the pregnancy being high risk. It's, well, what are you at risk for, right? So an IVF pregnancy, sure, there's a risk for a slightly increased risk, again, not to scare people, but a slightly increased risk of birth defect. So, okay, you get an advanced ultrasound, but you don't need to have your delivery by an MFM because of that. So you're slightly increased risk maybe of preeclampsia or something. All right, so whatever, take a baby aspirin, you get washed like every obstetrician, but you're not at an increased risk of a lot of other things. And so you have to focus on if there's an increased risk, for what? And as long as that's being followed correctly, either by your OB or maybe by an MFM periodically, like for an ultrasound or this, then it should be fine. And, around the country, most MFMs don't do obstetrical care and deliver babies. Most MFMs, hang out and do ultrasounds and consults and maybe some procedures.
I would actually say it's half and half.
I thought it was 70-30. Who didn't?
You know what? We should.
Last census.
We should look that up because I thought it was 70-30 and now it's more like almost close to half and half because of the M and MFM,
all those youngsters
like
doing
that.
deliveries. All right. So let's
they're
say,
loving it.
Either way, let's say it's half and half. So it's not, so for some people, there isn't even an option to have full care and delivery by an MFM, which is usually fine. Okay.
Yeah, because we all have, we all go to OBGYN school. And then the only things that MFMs do that are extra is ultrasound training and some critical care training.
Right. And research.
Yeah. So otherwise we're all the same. So, who do you like?
Yeah.
That informs your pregnancy care.
Love it.
Who do you want to be? Yeah. I like this analogy about the height because I always say, on that continuum, I always say, I can't define risk for you. That's a very personal thing. And it's kind of a moving target. And I use the analogy of like, how long is a piece of string? And people always look at me confused. So now I'm going to start saying, I'm 5'9".
Right.
Is that,
Right. You could also use religion. There's always someone more religious than you. There's always someone less.
Yep.
Always. Like, there's only two people on
That's
earth
true.
who don't have someone more or less religious than them.
Who are they?
The most religious and the least religious. That's it. Everybody else is in the middle.
I'm like, do you know them? How interesting. Let's get them on the podcast.
I made note of the one who's all the way the least. No. All right. Great. Next question is
Thank
from...
you, Mary.
Yeah. Next one is from Jackie. Hi, Dr. Fox, and I will add Dr. Feltovich. I listened to your podcast on early pregnancy loss, and you mentioned a few different scenarios, but noted that if you see a heartbeat and viable pregnancy in the uterus on ultrasound, the risk of miscarriage reduces drastically. I recently had this happen to me where I went in for an ultrasound because I had light bleeding at 7 weeks. Ultrasound and blood tests confirmed that everything was normal and on track, but then the next day I miscarried. If there was a heartbeat, then what was bleeding? Did something in the body cause the miscarriage? Example, an issue with the placenta. I'm curious what is actually happening in that situation versus a situation where heartbeat is seen and the patient has no bleeding or symptoms. Note, I had a subchorionic hematoma in my first pregnancy that resolved. Could these outcomes be related? So basically, Jackie, I'm sorry you lost the pregnancy. Obviously, that's hard. It is true that the risk of miscarriage is much lower if we see a heartbeat on ultrasound, but it's not zero. And so the question is,
it's never zero.
Yeah, never. Right. So why would someone have bleeding and lose a pregnancy after seeing a heartbeat and everything looking fine at 7 weeks?
Because you're looking early.
Yeah.
As opposed to later. And we don't know how to define where we are in the process. And that's why the only thing we have to offer is reassurance that the pregnancy looks normal at this moment and counseling about the reasons to come back. I do want to mention that there's nothing wrong with your body. So if that's what the question is, why did you do okay with your first pregnancy and then not this one? There's nothing wrong with your beautiful body. It can make babies just fine. And that's one thing that it seems like patients are always in danger of trying to figure out like what they did and, lay these things on themselves. And it wasn't that. As I'm sure you went over on your podcast about early pregnancy loss, the most common reason is that there's something chromosomally the matter with the little embryo that is causing it and its placenta not to grow and develop appropriately. And, Nadie, I don't know if you ever really reflect on this, but sometimes when I think about all the DNA divisions that have to happen properly for someone to come out semi-normal like you and me. Semi.
Yeah.
Emphasis on the semi, but other people are probably like straight up normal. I don't know. It's kind of astonishing to me that any of us ever get here.
I tell people that all the time. I say that the crazy thing is that it ever works out.
Yeah.
Not that it doesn't work out from time to time. It is.
Exactly.
It is miraculous.
I was going to say it's a miracle, like a literal miracle.
Yeah. So I agree. I think that, like you said, in the first trimester, the overwhelming majority, not 51%, but the overwhelming majority of miscarriages are due to something that's abnormal in the embryo from day one, right? You just don't know it. And it is true that most of those that are genetically abnormal will miscarry before there's a heartbeat. And that's why when you see a heartbeat, the likelihood is reduced. Now, there are still many pregnancies that'll miscarry after there's a heartbeat that are genetically abnormal. And so that is probably the most likely reason. Sometimes, even if we test the chromosomes, they are normal, but that's really just the tip of the iceberg. And so we don't, the depth of genetic abnormalities that's possible is way, way, way greater than what we typically would even test if we checked on a first trimester miscarriage. So I would say...
Right. And the breadth of what really can go wrong genetically, we're just scraping the surface of.
Right.
I mean, we don't know what we don't know. So even if we do a super deep dive and, even if we were to look at every single thing in an embryo or a fetus's genome,
we may still not know.
We may still not know because we don't know what we don't know.
Yeah.
Growing all the time. Anyway, not your fault.
Definitely
Bottom
not.
line.
Definitely not. All right. Our last question for today, for this Mailbag podcast is from Sarah. Hi. Thank you for your wonderful podcast. I'd like to submit a question for the Mailbag.
How many exclamation points on that one?
Well, this is more of a formal writing, so not as much.
Okay.
Yeah. Okay. So,
all right.
Sarah, I could have used an exclamation point.
I mean, next time.
Okay, that's fine. I'm not offended or anything like that. All right. I'm currently 32 years old and I have 5 healthy children. My pregnancies were uneventful other than being diagnosed with gestational diabetes during my last pregnancy at age 30, which remained under control. Around a week after my last delivery, I was feeling very short of breath, and my OB recommended I go to the emergency room where I was diagnosed with peripartum or postpartum, it's PP, cardiomyopathy. I'm being monitored by HF, I assume heart failure, and PP cardiologist, I assume peripartum cardiologist, with a slow but steady increase in my EF, ejection fraction. My doctors had told me that I'll likely need to be on medication for life. I'd like to understand what causes this condition. Does the risk increase with every pregnancy? Or if one's pregnancies are in close succession, I guess hers were. Is it possible for me to ever be totally cured? How would this impact future pregnancies? Thanks in advance for addressing this topic. So this is a big topic, and this is a tough situation. So Sarah, I hope you continue to recover. This is no joke. Cardiomyopathy is a big deal. So Dr. Feltovich, talk a little about peripartum cardiomyopathy.
So I wish I had one of my obstetric cardiology friends here next to us because they could address this more. But I will tell you that the good news is I must be getting old because I keep comparing today with how things were like when I started. I distinctly remember the first patient that I saw with peripartum cardiomyopathy because the cardiologist came, her ejection fraction was terrible, 25%. And they said, this is awful. You'll be on medication forever and you should never have another baby, and it was her first baby actually. And she was early 30s. So, none of the typical risk factors, genetic ones, I'm sure. And I thought, oh, this is bad. This woman might not even live and, whatever else. 6 months later, she was off all of the medications and doing great. Her ejection fraction had returned to normal within 2 weeks and she was doing great. I remember that patient because while it is, full disclosure, I am not a cardiologist, but it does seem from my cardiology colleagues that we co-manage these patients with that the outlook today is much better than previously thought. And in fact, postpartum cardiomyopathy probably happens a lot more frequently than we think, and we don't realize it.
Right.
So, and I know I'm searching my brain right now, but I know that there's some really interesting research going on in the space of, is it the fibroblasts or, like actual heart inflammation and heart muscle cells.
Right.
Looking at cardiac remodeling
the
and how
and the myofibers and all that stuff.
Yeah, I think so. I'm like, I probably haven't read about this for 2 years now, but so I'm sort of searching my memory bank. But the bottom line is that we don't know as much as we need to, but it is not the scary Dr. Google type thing that I think it used to be.
Right. I mean, I think that.
Do you agree with that?
Yeah. I mean, essentially, it's tough because the term peripartum or postpartum cardiomyopathy basically means you get heart failure during or right after pregnancy, thought to be somehow related to pregnancy. Exactly why that happens to some people, not other. We know risk factors, but we don't really get it. Number one. Right. Number two.
And is it an immune function? Is it an inflammation? Yeah.
And also on top of that, like you said, there were probably people who had very mild forms of this where they just felt weak or short of breath and just let it ride. And they never got an echocardiogram or saw a cardiologist, so never got diagnosed. Okay. And also people who have it, so it could be mild to severe. Some recover, some don't. And so that was always part of it. Like, we don't know what's going to happen. So I think that, like you said, the treatment of heart failure is a little more advanced now than it was 5, 10, 20 years ago. And then there is a recurrence risk, and it tends to sort of, so different people feel differently about that, right? If there's a recurrence risk and it's more than 0, does that therefore mean someone shouldn't get pregnant? Or does it have to be above 1%, above 2%, above 5%, above 10% in order to, and there's no right or wrong.
Now we're back into how do you see
exactly.
risk?
So it's very tough. And we've known for a while that people who recover and recover quickly, when they get pregnant again, have a greater odds of doing well than people who don't recover or take a very long time to recover.
Yes.
And so we sort of know that. So I guess a lot of it depends for you specifically, Sarah, about how long does it take to recover, what's your function like, and what will the risk be in the next pregnancy if you choose to have one. And some of that will be known and some of that will be unknown. And so hopefully your doctors can give you at least brackets around that, like best case scenario, worst case scenario, what are the odds of those? And then you could decide, is that something you want to embark on or not? But there definitely is some risk. It's just a matter of figuring out what the chances are. How low is that risk versus how high is it?
I remember back then, and this has been 20 years, the cardiologist recommending to this patient that she never get pregnant again, even though at 6 months she had normal function and was on no medications.
Yeah, probably because the risk is 1, whatever it is. I don't know the exact number. Let's say it's 1 to 2%, and they'll say that's too high for us, right?
Well,
and others might feel differently.
Well, they actually quoted her like a 50% risk. This was 20 years ago.
Yeah, that's probably all comers. That's not precision medicine, as we say.
It's not. Yeah. And today it's very different because I had a patient with postpartum cardiomyopathy 3 years ago, and the counseling was entirely different. Yeah. Less than 5% risk. So she was just like this patient who had recovered, less than 5% risk of recurrence. Those are very different things. Yeah. So the science is progressing.
Very nice. All right. Helen, thank you for answering Mailbag. You rocked it. Good job.
This was so fun, Nady. When can I come back?
We're going to do it. You're coming back. We'll schedule it.
I can't wait.
All right. Thank you for listening to the Healthful Woman podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.